Deepak, thank you so much for agreeing to this podcast. Just wondered if we could start off with why you think integrative medicine matters.
First of all, Elizabeth, thank you so much for having on the NCIM podcast. It's a pleasure to be here talking to you. I think to me, integrative medicine is able to bring in a lot of the modalities that we know helps in whole health creation. Specifically with my subject, which is pain management, I've realized that often you can have very good quality evidence base for many of the treatments that I do. But then there are others wherein we are dealing with how pain impacts on the mental health, on the spiritual side. And we know that pain is a very complex, multi-layered condition. And for those aspects there, it's important to bring in a variety of treatment and management options that are person-centered. And I think integrative medicine fulfills that aspect of thinking about the right aspect of management options that come from both evidence-based, as in the scientific randomized controlled trials, to actually then a variety of other treatment options that may not have the same rigor of evidence, but nevertheless can make a big difference in an individual patient. And I think that is where I feel integrative medicine fulfills that criteria of being able to offer that person-centered approach.
Yeah, I think that diversity is really crucial, isn't it, for us as well as our patients? Because if we've got a lot in our integrative medicine toolbox, we can connect, we can keep hopeful. There's always something that we can offer or connect with. And I think it's time, because we've got such a diverse population in the UK, but when you get the lens and look globally, we've got a huge diversity of the way people approach health and well-being.
Absolutely. And I think specifically, as you said to the last point, the UK is much more a huge multicultural society with so many different ethnicities, religions, viewpoints, all present in there. When I grew up in India, I don't think we had a lot of sort of language related differentiation and diversity. But coming here to the UK and now having been here 20 years, I can see that there is so much more diversity in thoughts, in religion, in language, in culture, in food. And I think we need to be respectful of all of that variety that it brings when we live and work in the UK.
Yeah, and I love the way you bring in the evidence-informed model, but also this respect, which I think is really important, just to inquire and be curious about the way people's diverse cultural experience may influence how they want to connect with us. And I see that all the time.
Absolutely. And I think it's something we recognize, so there's often this understanding or differentiation that people ask me, both in clinical practice and even to my friends and colleagues, as what is the distinction between integrative medicine, lifestyle medicine, functional medicine? I'm part of the trustees of the British Society of Lifestyle Medicine. And I think it's great that in the last 5-10 years, I've seen such a sort of growth of recognition among these various organizations that look at health than just the pure, what we traditionally call the mainstream evidence base there. But I think lifestyle medicine kind of comes somewhere again on that spectrum there. And to me, and I think I'm going to try to remember this right, Elizabeth, with the BSLM, which is the British Society of Lifestyle Medicine, we define lifestyle medicine as sort of a more evidence-based clinical care that takes into account all of these elements, the social determinants of health that we know are so critical in how our patients live and the societies they live, the behavior change through person-centered techniques, and to improve sort of what we call as the 6 pillars, which can be mental well-being, social connection, healthy eating, physical activity, sleep optimization, and then the reduction or minimization of harmful substances and behaviors. And I think it's kind of bringing in that base, trying to find what would be the most appropriate evidence in these 6 pillars and putting it together is lifestyle medicine. As I said in my initial forward as well, with specific regards to pain management, we know that there is a greater appreciation of some of the other techniques that don't strictly still have the full quality of evidence base, but nevertheless are so useful when it comes to supporting my pain patients. And I think it's recognizing those that where integrative medicine really makes and comes to the fore.
And I was so excited at the BSLM conference to see so many doctors and healthcare professionals in the room together. Like there were 400 when I was there. And I was like, wow, like if lifestyle is the way that we can have the conversation about the transformation of healthcare, then let's do it, because we want people to be comfortable, want doctors to be comfortable about what they're learning and what they're recommending. And for some, the integrative medicine might take them a step too far into diversity. For others, maybe with a background as yoga teachers, they might love learning about Ayurveda, or they might have used acupuncture or actually trained in it, and so they love traditional Chinese medicine. And I feel like the model needs to allow everyone to sit comfortably in it, just as we want our patients to be able to sit comfortably and be able to relate. So I'm going to get on to the pain in a minute, but I wanted to celebrate the British Society of Lifestyle Medicine and what you've achieved.
Thank you so much for that. And I think exactly as you said, Elizabeth, it's recognizing that a lot of our medical professionals, because they have been brought up so much in sort of the strict biomedical model of double-blind randomized controlled trials to be taken on board before you sort of drive any treatment for your patients. Sometimes some of the other modalities that come with that base of less evidence than usual has been difficult to accept. But lifestyle medicine and all the societies across the world that have got now a society of lifestyle medicine in the individual countries have all kind of just taken that little bit along the spectrum to recognize that we need medical doctors or physicians or clinicians broadly and healthcare professionals of all description to recognize the impact that public health, prevention, all of that has a role to play in how we talk about it in healthcare. And I think there's one sort of very nice graphic that I often talk about in relation to health, is that we recognize that what we do in traditional healthcare only accounts for 20% of what contributes to a person's well-being. And so if we want to promote a salutogenic approach, we need to bring in that focus on the remaining 80%, which is comprised of the physical environment, the socioeconomic status, and the health behaviors that people adopt. And it is a growing recognition that we as healthcare professionals, in whatever training background that we may have, whether we are physios or medical physicians or osteopaths or acupuncturists or any other school that we come from, we need to have a responsibility and a role in talking about that 80% and raising awareness and contributing in some meaningful way to make some impact in influencing that 80% as well, so that we are part of the salutogenic approach to improving someone's health.
And I love that word, salutogenesis, or health creation. I think many of us as doctors, when we were young, maybe I was 7 when I decided to be a doctor. I'm going to find out more about your journey. But I think we all had this idea that we would be supporting people into better health. And I think it's exciting for doctors to diagnose and some of the technologies. Ultimately, a lot of the time, we love it when someone we've been seeing will come back and say, okay, I'm feeling better, I'm feeling happier. And I think that's often a joy for us in our work, isn't it?
Absolutely, absolutely. I think that's in some ways, that's what I've rediscovered over the last 5-6 years of embracing this much more integrative lifestyle medicine based approach, a trauma informed approach, that there is joy in every consultation, that even if I cannot find the cure for their pain problem, I'm able to make it sound so much more sensible and person centered that patients actually come back with that and say, you know what you told me that day made a difference. I've now done these things, and it's that combination of things that's really brought about a big difference to their health, and that's what they're grateful for. And that's still really great for us to hear.
And it's often a combination, isn't it? It's not a single thing, it's more a combination.
We wish, but I think those of us in the field have realized, isn't it? It's never a silver bullet.
And it's often a journey to finding more balance in our lives, ways of building resilience. And that's very individual or personalized. And so part of the journey is to find out what's going to work for someone. So what was your journey into this broader model? Like, how did you make that shift? You said kind of 5 or 6 years ago, but what was happening for you that you kind of made this shift?
So my journey is coming with the sort of specialism in pain management. I had trained in India after having done my undergraduation in medicine. I did a post-graduation in anesthesia, intensive care, and pain management. So that was the sort of common way we trained in India. And then I came over to the UK almost 20 years ago and sort of undertook further training in Oxford and did my pain fellowship in UCL and London. And I took up a consultant job in Reading at the Royal Berks Hospital. And I was a secondary care consultant doing quite well, enjoying my work within anesthesia and pain management. But I think within the first 3-4 years of doing the secondary care pain clinics, I was realizing that everything that I'd learned in the fellowship, which was about interventions, being able to prescribe medications, strong opioids and gabapentinoids, understanding the pharmacology and all of the associated medical bits, wasn't necessarily giving the outcome that I thought it should have. I knew about the biopsychosocial approach to pain as well, and I had been working with physiotherapists and psychologists even within my team. But I was finding that despite the best of what we did for any patient, whether it was physiotherapy or pain psychology or interventions, injections, epidurals, nerve blocks, medications, only about a third of patients were actually getting meaningful outcomes and meaningful improvement such that we could discharge them, and I was confident that I would not need to see them again. Otherwise, every 3 or 6 months they would be referred back, and that really constitutes a major problem even now, that for musculoskeletal pain and chronic pain, we don't have anywhere in the country where the waiting list or waiting times are manageable at all. Every pain clinic that I hear about has got an average of 6 to 12, 18 months for any kind of treatment. And that's when I realized that the model that we have been doing and the way we understand pain was really flawed in some way. And that was kind of my wake up moment in 2015, 2016, when I realized, well, what am I not doing? What should I be doing different? And how could I really make a difference? And that's when my choice was either to just keep quiet and sort of do private practice and stay online and be happy where I am, or actually try to understand and read up a little bit more, be more curious, as we talked about, to say, well, what was missing? And that's when I realized, actually, as far as pain management is concerned, as far as the neuroscience of pain is concerned, and our understanding of what actually happens when somebody is left with chronic pain or acute pain or pathic pain, has been such a sea change of understanding and advancement that none of that really had made it into the actual treatment options at the coal face. And the more I read, I realized that there were so many ways we could meaningfully alter pain. Studies, good quality evidence was already there, but there was no practical way to bring it to the clinic. And that's really been my journey over the last, now coming close to 10 years. I finished sort of doing the reading by 2017 or 18, and I realized there's enough and more to read for the next 20 years. But I needed to really start the process of talking about it, talking to my GP colleagues, talking to patients. And that's really been the journey that I've been on for the last 6 to 8 years, is spreading that message that we need to probably embrace a more trauma-informed. And what I now understand is that integrative lifestyle medicine-based approach, because like you said, how do we get our colleagues to embrace this approach? And I think lifestyle medicine and the BSLM came about the right time, when I realized that all the evidence that I was picking up for what's required to be done in pain management is what the BSLM and the NCIM is already talking about and doing it in small pockets amongst the practitioners who are interested, invested, learning to do it. And my thought was, well, how do we connect secondary care and primary care, which is where most of the NCIM and BSLM physicians were, and how can we get this connection to actually say, for the patients, this is a seamless approach. Wherever you are, primary or secondary care, there is an opportunity to provide integrated care with knowledge that is uniform across the system, and that knowledge does not need to sit in a secondary care pain clinic. It ought to be given as early to the patient as possible, so that treatment options increase. And that's really been my journey over time to realize that I can make an impact. I could try to make an impact.
I have been deeply inspired by your work and very grateful that you spoke recently at our trauma-informed conference, which is part of our master's program, training healthcare providers. What I was really struck by is some of the work you're now doing in your pain clinic to reveal the rates of adverse child events and how, in order to really understand pain, we need to understand what's happened to people. I wondered if you might say a little bit more about that work you've done.
Absolutely. I think one of the part of my reading, and we sort of rewind back to 2017, here I was sort of reading up all everything around, nutrition, sleep, everything that my physiotherapists and psychologists were talking in their pain management programs, that you need to do stress management and sleep and movement and exercise and all of this stuff. And there was this book that I read, which was The Body Keeps the Score by Bessel van der Kolk, and a couple of other books in that same ilk at that same time by Gabor Mate and there. And I came across this repeated theme of adverse childhood experiences, and actually found the original study was done in the 90s, and there was evidence that there was an impact with regards to chronic pain and adverse childhood experiences. And I was really surprised that nobody seemed to know about it. Nobody was talking about it. And I was wondering, well, does it really have an impact? There were already studies or case studies and series reported in literature around how adverse childhood experiences seem to be having an impact on chronic pain presentations in adulthood. And I thought to myself, well, how relevant is this? And I took permission from my ethics and governance body in my own hospital. And I thought, well, how about I test it in a secondary care service to understand what was happening? And so for a period of probably 10 weeks in 2018, I got the permission and approval for about a 10-week period in my pain clinic, every new patient to be given the original questionnaires. For your listeners, the Adverse Childhood Experiences score is a standard 10-question sort of questionnaire that was designed in the original ACEs study published in 1996. We now realize, of course, 20 years on, there's probably a lot more that needs to be said about adversity in childhood. It's not just those 10 questions. There's a lot of adversities that could be reported in childhood, and there are more questionnaires out there. But this was the original seminal 10 questions that looked at 3 questions around physical abuse, 2 questions around sort of emotional level there, neglect and abuse, and then 5 questions around family dysfunction of a variety of kinds. And this is what I gave to my new patients who were checked in or referred to the pain clinic from anywhere, whether it was GPs or secondary care. And alongside that, I also asked some questions about their resilience and the other medical conditions that they may have. For a period of 10 weeks, we roughly had about 150 new referrals, of which 134 of them filled out the questionnaire incomplete. And so I had at least 134 good data set. And what was very revealing and in some ways a little bit surprising and shocking to me, we did have a question based on what my psychologist suggested, was that rather than just to give the 10-item questionnaire, which can be feeling very brutal and personal, is to actually just ask a question, did you have a happy childhood? And that was just a yes or a no. And if they said yes, then the questionnaire wouldn't pop up. But if they said no, only then it would come out. And 37%, which was almost 43 patients out of the total number, absolutely volunteered the information that they did not have a great childhood. And then when we offered the 10 standard questions, like did you have physical, emotional abuse, sexual abuse, or physical abuse, or sort of neglect, and then emotional abuse or emotional neglect, and then after that you had family dysfunction, 75% of them agreed that they had 4 or more such adverse childhood experiences. And the reason I say 4 is that in the original study, as well as in a number of other studies that have been reported on ACEs since then, in many countries, developed or developing countries, 4 seems to be the clinically significant number beyond which people can have various symptoms impacting their mental health and physical health. And in that study, in my own pain clinic in a secondary care pain clinic in the UK, 40%, 37 to 40% of new referrals were reporting that they had a unhappy childhood, with more 75% of that group having 4 or more adverse childhood experiences. And these people all had other medical comorbidities. They all had multiple visits to the other specialities for their problems affecting various conditions, organs, and they had also been coming to the pain clinic as well. And this was something that nobody in healthcare, secondary care especially, appreciated the importance of that. And I think that is something I felt should change. And so when that result came out, ever since 2018, every time I've been asked to give a talk, whether it's to GPs or healthcare professionals of any descriptions, secondary care professionals, I've presented at the Royal Society of Medicine, at the Royal College of Anesthesia, at the Faculty of Pain Medicine, and at other national forums within BSLM and at NCIM as well, is this approach to trauma-informed care. We need to be very aware that trauma impacts the nervous and immune systems significantly, and when that kind of repeated immense stress or trauma occurs in childhood, i.e. before the age of 18, when the nervous and immune system is developing much more rapidly, with certain periods being highly intense activity, these are very critical times. And when people have intense persistent stress or trauma or adversity, the impact on their immune and nervous systems can be so significant that it presents a great amount of vulnerability. And now the data has come out, systematic reviews and meta-analysis published in really high impact journals over the last 3 years have shown that trauma is exceedingly common. There is a strong case to be made for ACEs screening of some description within the pain clinic, and for services, especially pain clinic, but generally I would argue that across the board in healthcare, do need to have some way of being aware about trauma and its pervasive influence, so that how we communicate, I don't mean that we need to document ACEs score in everyone and try to treat that. I don't think treatment is required. But I think raising awareness, like the way we are often asking about people's allergies or smoking history or family history, this is something we need to be routinely documenting so that we can recognize as healthcare professionals how we should be communicating information, how should we be thinking about the vulnerability of the nervous and immune system sitting in front of us, and look at the person as a whole rather than just thinking about their diabetes or their COPD or their autoimmune condition or their cancer or their chronic pain. Because we now have the data to say that when you have significant trauma, it has an impact on the central nervous system, it has an impact on the immune system, it can present as mental health disorders, it can present as cancer, it can present as metabolic syndrome, it can present as autoimmune conditions, and it can present as chronic pain, functional neurological disorders. And I think that awareness is the sort of social campaign that I'm trying to be part of.
Yeah, amazing. Vital bit of work. Partly because it drives a very compassionate model of healthcare.
Absolutely.
It allows the narrative to arise. We're not saying that being aware, you might kind of, look at trauma release, that will be a team, but because you're aware of somebody's actions and experience being related to trauma, then compassion can come in. And we were learning about the different ways trauma might present. It might be an aggressive agitation, or it might be a passive lack of motivation. These are just 2 of kind of 4 responses. But for me, I feel as modular lead teaching around holistic consulting on our master's program, that what I felt when I was listening to you is, again, you were trying to get back to the conversation before you might decide on how to support that person. And I'd like to tease out how your prescription might look different at the end of a consultation because of being trauma informed and also because of your lifestyle training. I wondered if you could share how it might look different at the end of a consultation with you.
Absolutely. Thank you. It's a great question, and I think that would bring it to life, hopefully, for your listeners and viewers as well, Elizabeth. So let's let's think, I often talk about this one patient I had a few years ago, and she was referred to me from the orthopedic surgeons with a hip pain. And the aim was actually to refer to the pain clinic for consideration of hip injection because she was in her early 40s, and therefore it meant that she can't have a hip replacement for her moderate osteoarthritis. And there she was sitting in the pain clinic with me and talking to me about the history. She came with her partner. She had a good relationship, and I did my usual sort of biopsychosocial assessment, talking about various things there. But I also had a questionnaire, and before she came to the pain clinic, which is my practice there, I did send out a questionnaire to her. And part of the overall set of questions, apart from asking about what medication she's on and what treatment she's tried for her pain, I also had a couple of questions looking at what her self-efficacy, so PSEQ was a scale that I had. I had a scale for anxiety and depression, and I had the ACEs score as well, alongside any other medical conditions. And she had volunteered actually that she had an ACE score of 6 out of 10. So I did know that she ticked the box to unhappy child and these scores there. And she had the scores for her self-efficacy, all the medications there. So I spent my consultations around 30 to 40 minutes, the new consultation, and it was all about establishing rapport in my first consultation. So I asked her for a story. I asked her, and I was able to actually just stay focused on listening to her, making some small notes and letting her tell me what she had hoped for. Because after all, she'd been to the hip surgeon twice. She's had 2 hip injections, both worked for only 6 or 7 weeks. She was not keen with a mid-40s and a young child. She was not keen to go on strong drugs. And she was looking to me to say, well, I don't want a hip replacement, but this is a problem that's been happening for 3 years now, and nothing seems to be working, and it's affecting her sleep, her quality of life, her mental health, and here we are. And until then, she was still trying to hold on to a job, but that was getting progressively difficult because she not only had this problem with pain, but she was having the caring responsibilities for looking after her father, who was starting to struggle with dementia, and she had to be caring. And during our conversation, I asked, well, where are the triggers? What's happening? And my choices were at this time do a sort of hip injection or a radio frequency, which is all the interventions I can do, and probably speak to her about stronger medication as a way of getting her to engage in rehab. These are some of the thoughts I had initially. And during the conversation, she kind of reflected on the triggers of when the pain occurs and what she does. And she talked about the fact that when she bends over to help her father, that's when it starts to hit the most. And at this time, I was just going through my various options of saying, well, what can we do? What would be the pros and cons of injection? And I asked her, well, actually, can I ask a question, hoping that at this time we'd achieved enough rapport with the conversation and how she'd been trusting and reflecting on triggers. And I use a lot of motivational interviewing style questions, a little bit of the trauma informed, but it is still open questions, trying to get some reflections from her, coach a little bit to say, what can we do about the triggers there? And it just came out. She said, well, I now realize that when I do bend down, this is when I was also having my trauma from childhood come back. And I was able to just unpack it and said, does she wish to talk about it? Why is it that bending comes there? And that's when she revealed that actually part of the problem was the abuse that she suffered. And this was the posture, and her father was the abuser, and here she was having to look after her father now, and her nervous system and immune system had been able to remember that memory. And this is in line with the way we understand the neuroscience, as well as to how the brain and nervous system codes for certain memories in order to protect us anytime in the future. And this is what she was saying. This is what reflected and came back, and that's when the pain was coming on. And this was the right time for me to actually just gently say that look at the ACEs literature. This is what we understand, that when people have adversity, and she had been through a share of it, it can present as a tightening of the muscle. It can present as a tightening of the pelvic muscles and the lower back. And that could be one of the reasons for a hip pain, because we now had the evidence to say that arthritis can be seen in people without any pain as well. So there was evidence there, and I could show her that it doesn't mean that just because she had mild to moderate osteoarthritis reported on her hip MRI or X-ray, that it necessarily was responsible for all the intensity of her pain. And certainly the injections done by the surgeons hadn't given her long-lasting benefit. So I just turned it around and said, what do we do now? We've got this situation where you've identified a trigger, you've identified a particular memory that brings on the trigger. And I said, I could do an injection, but it may not work. How are you going to alter this? And I may do a stronger medication, but then I have to be aware that if you are vulnerable, then that's when the risk of the addiction or dependence of the drug is highest. How can we mitigate this? And this now became a conversation where she felt equally empowered to say, well, what could I do to mitigate the risk? Because looking after her father was a priority. She couldn't escape that duty role. But how could she reduce that fear that she felt? How could she improve the safety of her nervous and immune system when she undertook that role, and therefore avoid being on stronger medications maybe? And we were able to arrive at a plan. It took about 50 minutes instead of the 30 minutes, but she was arriving at a plan which was almost self-constructed. And she said, well, you know what, I'll try this amitriptyline. And I want to do these 2-3 things and give me a follow-up in 3 to 4 months' time, and we'll see where we are. And 4 months later, she came back and we had a follow-up, and she said, you know what, ever since we had that conversation, I realized what could be the triggers. I realized that I don't have to fear now because this man in front of me is now in dementia. He wasn't going to hurt me like what had happened 30 years ago. So actually, somehow the fear of all of that went down and the pain didn't feel that much now when I was bending over. I had my partner anyway, and I spoke to him, and he knows. And he's been entirely supportive. And actually, I just took the amitriptyline for a week, but I didn't really feel the need for that because the pain's not affecting me that much. And our next consultation was, well, no need for the medication. She realized that she didn't need the injection. She probably didn't need the hip replacement anyway. She had an answer to do, and she felt completely happy in now understanding more about her body, the pain, what are the triggers, and she understood the lifestyle element that when stress happens, when low sleep happens, that could all be triggers for the nervous system. And so she was able to take more care, and she had done it a few times with hardly any pain or very little pain. And I said, there you go, I don't need to see you anymore. And that's been 2.5, 3 years now, Elizabeth. And there have been many such stories like this, but I hope this example that I had with this patient reflects what raising that awareness. I didn't have to treat her for trauma. She didn't need any kind of psychology referral for that. All she was to be heard, to be listened, to be validated, to allow her to make sense of her story. And that was enough for her to realize that her nervous system was doing the right thing in protecting her, but it didn't need to do that overprotection bit at this time in her life. And that was enough knowledge for her to move on and not require my services again and again. And I think that is kind of what I want to say, that, attention to lifestyle, trauma awareness, trauma information, and that can really be a powerful treatment approach for a lot of our patients who come, not just to the pain clinic. I think there are many other conditions as well where it makes a difference, but I certainly think for chronic pain and mental health, it's a huge opportunity.
I'm so moved by hearing that story because there are so many elements. It's profound the way that you, just in a way with a simple question like what are the triggers, that she could go inside into that kind of experience, that very traumatic experience, but also then the awareness. And then what I love is the way that, as you say, you co-constructed. What do we do next? What was wonderful is you didn't jump in as expert and say, oh, well, I know what you need. You said, what should we do next? And of course, then that built the trust between you. And as you say, to be heard and seen and your pain recognized. And I don't mean just the physical pain, I mean the way that life really wounds us sometimes. I was really touched to find that her duty keeps her in the loop. So she's generating that compassion for her father. But you facilitated what I love as well in my job is where the person basically sacks you, where they say, I don't need you anymore. I'm good. And I think that we, imagine the reverse spiral of increasing intervention, increasing pain, And of course, what I think we both find in our work is sometimes if someone gets to an expert who might operate, and there's no going back. Someone who can, at this point where it's still quite dynamic, kind of get in there and start to create change. Honestly, I felt like I was going to start crying. It's such a beautiful story, and you must do that a lot.
Certainly, having now feeling more empowered with this new knowledge that I have around trauma, around lifestyle medicine, I feel that I have in every consultation that comes and sits in front of me these days, whether it's in the NHS or in the private sector, I feel I have a menu of options that I can discuss with them, that I can make a difference. Sometimes, as we talked about in the beginning of this conversation, sometimes they may not be in the right place, and that is their journey. But many of them might be willing to explore a couple of options. If they can have a bit of curiosity, I am willing to have the curiosity to say, these are the options, these are the ways we can soothe your nervous system and give it the options to calm down, to ease down. And honestly, is a game changer in my head, because I don't feel helpless. And I think that's often breakdown of communication, complaints. All of these are happening when somebody feels that they have reached the limit of their expertise or their help. And I think doing this kind of approach and this philosophy has always left me with many things that I can offer. And it's about looking and exactly asking what matters to the patient. And certainly, even at the trauma thing, one of the things I do want to say is it's not just about the communication, but it's also about some of the changes I've made in my clinic consultation. I make sure that where I sit, the physical environment, of course, some of the times it's not under my control, but what is under my control is to ensure that patients are closer to the door than I am. I try to ensure that wherever I'm sitting in the room, I am further away from the door, the patient is closer to the door. I try to ensure, and these days with a lot of these AIs in scribe software, I try to ensure that my attention is completely at the patient. My body language is indicative that I'm open to receiving information. I don't turn away from them unless and until it's to look at an investigation or a scan. Otherwise, it's about getting rapport and engagement. Little bit of voice option is I also ensure that my seat is preferably at the same level or actually a level below them in terms of eye level and contact, eye movement, sort of eye contact. And I try to, as far as possible, the first 10-15 minutes, they have full monopoly on what they want to tell me, where they want to go in their journey, how much they want to digress. I just let them talk. And in some ways, listening to the words that they say, the language that they use, all of this I suggest and I tell a lot of my colleagues and sort of trainees is this is all useful, because if we can get that 15 to 20 minutes of building rapport, building trust, then the next 1 hour, 2 hours, or multiple consultations are always going to be built upon this platform of good rapport, good understanding, and a beginning of trust. And I think that is critical. We realize if we want to bring about curiosity, change, compassion, then we need that bedrock of trust and foundation. Only then, when the nervous system starts to feel safety in trust, will empowerment and choice and collaboration can ensue from that bedrock.
Super important, all of those elements in setting the environment, the context, but also knowing that, the research shows that most clinicians will interrupt at around 17 seconds. So a lot of people have never told the story, kind of freestyle. And of course, as you tell your story, you're actually relaxing in your body as you unload. Yeah, I mean, these are beautiful things to hear. We're coming to the end. I can't believe how quickly it's gone, but I do want to mention this amazing book that you have written, and we'll put it in the show notes, the link, but also just that element of descending control. I worked in my training in palliative medicine in various pain clinics for many years as I trained part-time bringing up my family, and I love my pain clinic work. Like you, I found that, the medications were useful to a point, but really understanding distress, despair, how it manifests in the body. But the neuroscience has really shifted since I was training. So would you like to say a little bit about your book and some of those key scientific advancements that we have now in pain management?
Thank you so much. I do always have a copy of the book there. That's kind of my
Yay!
plug for it. Yes, often there. Why would I not be? That's my calling card these
Yeah.
days. A lot of the book came from the fact that this is what I was doing from 2016, 17, ever since I learned about all this neuroscience, all my talks, and that is what got distilled into the book published by Vermilion in a couple of years now. There's both the audible version as well as the book version available. Where this came from is essentially I wanted to write something for patients that would give them the understanding of the neuroscience of pain as we understand it now, and then allow them to create a template based on the principal pillars that pain management needs to have. Any person's personalized plan needs to have these elements in place. And then I talk a little bit about the third step is in how can we bring about the change. And even there, bringing about behavior change, the neuroscience of it, of how somebody learns, how a nervous system learns a new way to do things, has now got a lot of scientific basis to it. And broadly, I think from the science side, what has changed is we've now recognized that while there is a nociceptive pain, which is the pain when you have acute injury, then you have neuropathic pain, which is when you have a nervous system structural damage, like in diabetes or multiple sclerosis or stroke. These two are things that often all of us as medical or healthcare professionals are taught about in our healthcare schools. But we now have realized, and in 2017, the International Association of Study for Pain recognized a third category called nociplastic pain. And this is a group of conditions wherein the nervous system is neither inflamed nor damaged, but nevertheless, the nervous system gets upregulated, often in conjunction with the immune system, which also is overactivated. And so this combination of neuroimmune activation and upregulation of the nervous system is what gets called as nociplastic pain. The examples of this nociplastic pain is many cases of chronic pelvic pain where there's no endometriosis, irritable bowel syndrome, chronic migraine, a lot of non-specific or specific low back and axial neck pain and low back pain, which is non-specific, meaning not from a defined spinal structure. And once you look at this 6 or 7 conditions that I've outlined, you can see that that is often the biggest group of patients that come to any primary care or secondary care service. And so actually, we now had the suggestion that 1/3 of nociceptive pains will also become nociplastic, and up to 2/3 of neuropathic pain also become nociplastic. So upregulation of the nervous and immune system is occurring across the board in all chronic pain conditions. And chronic pain being the most prevalent, impactful condition economically in most countries. This is where I think my book can play a part, because for managing nociplastic pain, right now, the NICE guidelines find that there is no satisfactory drug other than maybe a short-term trial of tricyclic antidepressants like amitriptyline and duloxetine. There is no intervention or surgery that can fix this. And ultimately, all the techniques are around what can we do to calm an overprotective and oversensitized nervous and immune system. And this is where knowledge of the neuroscience and stress management techniques, knowledge of movement practices that can rebuild new nerve circuits, knowledge of sleep optimization because of the bidirectional impact it on the sleep, knowledge of nutrition, which has a powerful impact on the immune system and then on the nervous system, and mind-body techniques, a lot of integrative medicine practices and ways of reducing other harmful substances and behaviors. And this is where the combination of lifestyle medicine and integrative practices really comes to the fore, is in managing and turning down nociplastic pain. There are ways of retraining the nervous system with the work that's coming out from the US in what they call neuroplastic pain, but essentially you can retrain the nervous system. You can calm the nervous system down and give it enough safety that you can actually take it back to a pain-free state. And that is the kind of recovery stories that are now coming up across the world when people understand and can retrain the system, we can actually achieve sometimes freedom from pain. I think we need to study that a little bit more rigorously to say what is that magic set of options that make somebody pain free, because I know people now, even in the UK and in the US, I've met them who are now pain free after having 10, 20, 25 years of debilitating pain. We need more research to understand how that happens. But seeing that it has happened means that these techniques can make a difference. And these techniques aren't really made available to a lot of our patients. And that's kind of where my book sits right now, is how can we make this understandable to the population at large? How can we understand predictive, protective influences that the brain engages in? How can we explain that to the general public and bring in the treatments of nociplastic pain and use coaching and other team-based approaches to give a person-centered integrative model? That is the stuff of the work, and that's what is there in the book.
It's absolutely wonderful to hear that. And it is healing in a way, isn't it? It's allowing the body to return to an optimum balance that, before the injuries occurred, either emotional or physical or viral, or where inflammation started to build up in the body. We know that can be super important now in pain to reduce inflammation. But what you've just described is so many things that are available, and that brings hope. And hope, I think, can be the pathway to feeling, I could be different and I could experience life differently.
Absolutely, Elizabeth. And I think that is the crucial word. There is hope. And I think for your listeners, for your viewers, that's what I'd like to sort of definitely leave as a very important message from my book, from my talks, the work that I do, is that there is a lot more hope than we ever thought possible. And that is really the message we want to give to a lot of our patients.
I think that's a wonderful place to leave it. Thank you so very much to the listeners. We'll put lots of information and links to some of the papers that Deepak's described, to your book as well. And our conference proceedings will be on our membership site. We'll give you a link as well, because you'd be able to hear Deepak's talk and others around chronic pain. But I do want to say a real genuine thank you, Deepak, to your courage to do things differently and a kind of a natural compassion that's alive in you to be curious. And I love that. So thank you.
Thank you so much, Elizabeth, for having me again, and wish you all the best with the NCIN podcast. Thank you.
Thank you.